And I want to thank you very much for joining us to honor and celebrate the life and career of a remarkable colleague, Dr. Giovana Thomas Smith. With this inaugural endowed lecture by Dr. Gina Jefferson, one of our former head and neck cancer surgery fellows who herself enjoyed mentorship with Dr. Thomas. I think we'll be honored this morning by having in person joining us Giovana's husband, Dr. Damon Smith, and one of their two sons, Sebastian, and some close family friends as well. And on Zoom, we have sisters Crystal Thomas, Idanya Thomas, and Dr. Tanya Thomas Presswood, brother-in-law Donald Presswood, and nephew Zevi Ford with us virtually. Welcome to you all and to our friends and colleagues from around the country. Dr. Giovana R. Thomas Memorial Endowed Speaker Series was established over the last year with support from many members of the department, resident fellow alumni, and grateful patients. Thank you all for your support. We're still accepting donations to grow the endowment. The annual speaker series will include invited specialists from around the world to give presentations on cancer and other diseases of the head and neck with a focus on health disparities, the delivery of care to patients in underserved communities. The series will also focus on opportunities and challenges with regard to access, equity, and inclusion in the delivery of head and neck patient population. In one of life's cruel ironies, Giovana, herself one of the nation's premier oncologic surgeons, lost her own struggle with cancer on February 23, 2023. Giovana was genuine in all of her interactions, open and honest with her emotions, and freely giving of her positive energy and friendship. She would enlighten the moment with her smile and her genuine happiness to see friends and colleagues. She reminded us directly and by her own example to slow down, take a broad perspective, and to bring a humanistic approach to the practice of medicine. Dr. Thomas, the head and neck oncology surgeon, was formidable. While her gentle interactions with patients and families earned the kindest feedback, highest survey scores, and fierce loyalty, her medical evaluations and surgical skills were exacting. We're fortunate to have one of the best head and neck cancer surgery programs in the country, and Giovana was an integral and important component of that excellence. Her many accomplishments are summarized in the Laryngoscope article about her life. If you haven't already read it, I would urge you to do so. I would just highlight one here, and that's the prestigious Mosher Award for her Triologic Society thesis in 2016, entitled Human Papillomavirus-Induced Oropharyngeal Cancer in Hispanics in the United States. She was the only thesis recipient invited to present that year. Giovana was an effective and sought-after teacher. She established many impactful mentoring relationships with trainees at all levels. She was passionate about inclusion, equity, diversity, and access to health care. And she didn't just pay lip service to these issues. She lived it, learned from her own experiences, got involved, researched the issues, and paid it forward by helping others in similar circumstances. An amazing physician, surgeon, wife, mother of two wonderful young men, sister, friend, and colleague to many here at UHealth and around the country. We miss her and will forever remember her smile. It's my honor and pleasure to welcome the Dean of the Miller School of Medicine and Chief Academic Officer of UHealth, Dr. Henri Ford.
Well, good morning to all, and especially to all of you who are joining us via Zoom. So colleagues and friends, I'm truly pleased to welcome everyone to the inaugural Giovana Thomas Memorial Endowed Lecture, honoring an amazing friend, colleague, and exemplary leader. Most of us are still mystified by the untimely and premature death of someone who was so vital to the success of the Department of Otolaryngology. And most of you in the audience are far more qualified to extol Giovana's virtues, her amazing intellect and skills that saved and restored hope to countless patients suffering from head and neck malignancies, and her ability to inspire and train not only residents and fellows in otolaryngology, but also the next generation of physicians and physician scientists. To quote from the beautiful and poignant tribute by Fred and Don Weed that was published in Laryngoscope in October 2023, Dr. Thomas will be remembered for her fierce determination and strength, her numerous accomplishments, her kind and gentle demeanor, her leadership as a mentor and role model, and the warmth and compassion she showed her colleagues and patients throughout her distinguished career. Although this career ended far too soon, her impact on the field leaves a lasting and important legacy. As Dean, I can say unequivocally that Giovana was one of the most accomplished and dynamic leaders in our health system. I got to know her when she emerged as one of the most thoughtful and influential voices in our quest to create a more just and equitable learning and working environment following the murder of George Floyd in May 2020. She used her influential status as the only Black female tenured professor at the Miller School to lead the efforts of the Task Force on Racial Justice. She was indeed a powerful and highly respected leader who helped establish the Society of Black Physicians and Scientists at the Miller School. I'm also delighted to welcome Dr. Gina Jefferson, a graduate of our fellowship program at the University of Miami and a mentee of Giovana Thomas, who currently serves as Distinguished Professor of Otolaryngology, Head and Neck Surgery at the University of Mississippi Medical Center, where she leads a dynamic head and neck oncologic and microvascular reconstructive surgery practice. It's great to have you here to deliver the inaugural Giovana Thomas Endowed Lecture. Thank you.
Gina is very eager to give her talk. So it is my distinct pleasure to welcome back Dr. Gina Jefferson to Miami to give this inaugural lecture. Gina is finished her residency at Loma Linda, and then we were fortunate enough to recruit her here to the University of Miami as one of our head and neck fellows. I am certain that one of the primary reasons that she chose us over other programs was to be able to train with Dr. Thomas. It's hard for me to even talk about this, but it has just been a tremendous honor working with Gina over the years, and certainly with her time here with us. Gina left us to go to the University of Mississippi Medical Center, and then moved from there to the University of Illinois in Chicago, where she was associate professor and served as residency program director. She returned to the University of Mississippi Medical Center as professor of otolaryngology and vice chair of education for the department. Gina serves nationally on many of our national societies and programs, but chief among those would be her service as chair of the diversity service of the American Head Neck Society. And I will say, as our inaugural speaker for the Thomas Memorial Lecture Series, this is not Dr. Jefferson's first time as an inaugural recipient. She is also the inaugural recipient of the Margaret F. Butler Award for mentoring of women in head and neck surgery. Our speaker committee for the Thomas Memorial Lecture Series was unanimous and excited in its choice of Dr. Jefferson as our speaker, and we're excited to welcome her today.
Good morning. It is indeed an honor to have this unique and prestigious role to serve as the inaugural endowed lecturer for our friend, mentor, and colleague, Dr. Giovana Thomas. I am excited to be back at the University of Miami. It's been so long, things have changed. But indeed, as I tell all my residents, fellowship is honestly one of the best times of your life, and in part, mostly because of who you're learning from, which obviously included Dr. Thomas. So today I'm going to discuss the legacy of Giovana, equitable care and outcomes in otolaryngology. Honestly, I originally intended to include examples beyond head and neck cancer, but with limits of time, we're going to focus on examples of head and neck cancer. I think it's only fitting that me, a former mentee of Dr. Thomas, is presenting this photo obtained from another mentee, University of Miami resident alum, Dr. Sandra Stinnett, class of 2017. In this photo is captured Dr. Thomas in the foreground. You can see her name on her headlamp. The resident in the photo is Dr. Rosemary Ojo, University of Miami resident, class of 2015. I'm of the generation that does not take photos and selfies, so I had to request them from all of you. I do have one financial disclosure. I'm a paid consultant for Cook Medical Incorporated. This has no bearing on today's presentation. So this celebration, or this endowed lecture series, is really to celebrate Dr. Giovana Thomas. She was an incredible educator who was always exhibiting the most patient demeanor with all of us in training. I remember one distinct episode where we were in the OR at the University of Miami Hospital. I was taking a third-year resident through a neck dissection, and she was not scrubbed in, but in the room. We got into IJ bleeding down near the clavicle, and she says in her Panamanian quiet voice with the accent, "Gina, you must control the bleeding." And so as I'm grabbing the vessel, the wrench keeps extending inferiorly to the clavicle. Eventually we control bleeding, but that was Giovana. She was not going to scrub in. She was determined to make me get the fellow and the co-resident working with me to control the bleeding for ourselves. As you all know, Giovana was a mentor not just to the University of Miami trainees, but to people all across this country, whether they were in training, whether they were a medical student, or whether they were a faculty member already. She always availed herself to be an advisor, a listening ear, and just a tremendous mentor. In addition, Giovana is a trailblazer and innovator. She really contributes significantly to the management of head and neck cancer, which I'll highlight a little bit later. I think for women, she was the best example. She was a tremendous wife. She was a tremendous mother, an excellent surgeon, an excellent educator, and all the while doing all of this with great generosity of her spirit and time. So some fun facts about our friend. In the early 1990s, Giovana's residency class of 4 had 3 women. There was someone back in the early 90s that was bold enough to train 75% class of women in otolaryngology. Giovana spent time during her residency at Georgetown doing an NIH research fellowship, which is important because your experiences inform how you trailblaze your career. Giovana was soft-spoken, as I mentioned earlier, but when she spoke, she did so with command and authority. And again, Giovana's mentorship extended far and wide, but I think one of the most prominent things about Giovana was she was one of the original nationally recognized Black female otolaryngologist-head neck surgeons. So my objectives of this presentation are to utilize some of the disparate outcomes in head and neck cancer, specifically laryngeal cancer and oropharyngeal squamous cell carcinoma, to drive this discussion and why it's important. I will follow with some etiologies of disparities beyond the biology of disease, and to provide some best practices for mitigating these disparities and provide a call to action so that we can indeed establish equitable outcomes in eliminating disparities. So to begin with laryngeal squamous cell carcinoma. For those non-head and neck surgeons in the audience, just to give you a description of what we're actually talking about, the burden of laryngeal cancer for 2024 comprises about 13,000 individuals in the United States who will be diagnosed with this disease. Most of them will be men. About 4,000 will die of this disease. The primary subsite that is diagnosed with laryngeal cancer is in fact the glottis, the narrowest part of the airway. So you would think that patients would present with disease earlier because they would experience symptoms earlier. About 35% of patients are diagnosed with supraglottic disease. The average age of diagnosis is 66, and Black men are more likely than white men to be diagnosed with this disease, and Black men are also more likely to die of this disease than their white counterparts. As we all know, or hopefully we all know, there's head and neck literature that really points to overall survival and the negative impact that certain race and ethnicities have on disease outcomes. This group of individuals set out to use the SEER database to identify whether or not racial differences have any significant impact on laryngeal cancer-specific mortality. What they found were that Black patients more frequently did not receive treatment. Blacks underwent chemotherapy alone more frequently, which means Black patients more commonly underwent palliative therapy rather than definitive management of their disease. Black patients more commonly underwent concomitant chemotherapy and radiation, signifying that Black patients more commonly were diagnosed with advanced laryngeal cancer. Similarly, Black patients in this study were found to more commonly experience trimodality therapy, again, a reflection of being diagnosed with advanced stage disease. And white patients more commonly received single modality therapy, a distinction due to having diagnosis at earlier stage. So with respect to laryngeal squamous cell carcinoma specific mortality, on univariate analysis, race was significant. But when we look at multivariable competing risk regression analysis, older age, presentation with nodal mets, so local regionally advanced disease, higher stage, and the socio-demographic factors of being unmarried, having less education, and geographic location of the patients when they were diagnosed. Those things still significantly contributed to Black patients having greater overall mortality than their white counterparts. But on stepwise regression, the most significant factor was still the stage at diagnosis, which again reflects some aspect of the social determinants of health that impact Black patients. So I think the observations that one can glean from that study is that access to care contributes to the stage that a patient is diagnosed. Makes sense. Social determinants of health are those non-medical factors that impact a person's outcomes with respect to any medical disease, contributes to cancer-specific mortality as demonstrated in this study. The SEER database obviously cannot identify specific barriers to care for specific populations studied or accounted for in the database, but individual patient sociodemographic factors are clearly at play. Black patients are less likely to receive definitive cancer treatment, which is significant and might reflect their ability to undergo care financially, the resources to get there with respect to transportation, and just having health literacy to understand the significance of their disease. Black patients are also more likely to experience higher rates of trimodality therapy, exemplifying their later stage at diagnosis. I think laryngeal cancer is one of the unique head and neck cancer sites with respect to how we treat advanced disease. Obviously, undergoing laryngectomy really impacts a patient's quality of life and how they interact with the world. How they breathe becomes completely different. How they communicate, completely different. And how they appear visibly to anyone with whom they encounter. So at the University of Mississippi, we're considered a safety net hospital. We sought to examine whether or not tracheoesophageal puncture outcomes were influenced by patients with lower socioeconomic status, and whether or not that impacted the timing of when we performed tracheoesophageal puncture, whether primarily or secondarily. And this work was presented at the American Academy of Otolaryngology meeting. We used the area deprivation index to represent patients' sociodemographic status. The area deprivation index is basically a neighborhood index that assesses the level of disadvantage of one neighborhood in comparison to another. Divided in quintiles, the fourth and fifth quintile represent areas of deprivation that are the most significantly disadvantaged in comparison to other neighborhoods. So in our cohort of over 200 patients, almost 90% were in this quintile. We did determine that there was no significance of ADI in its contribution to timing of placement of a tracheoesophageal puncture. We did find that overall in our study, just 53% of patients who underwent tracheoesophageal puncture as the accepted gold standard means of communicating after laryngectomy is relatively low. There was no significant difference with respect to timing, whether it was primary or secondary. There was a statistically significant difference in the mean age, younger patients more successfully using their tracheoesophageal puncture to communicate. We also demonstrated that with each increase in age above 60, there was a 5% decrease in the successful use of TEP, tracheoesophageal puncture, to communicate. With respect to use, we did not find, however, that there was any influence of race, ADI, insurance status, history of chemotherapy and radiation. I should tell you that over 50% of our patients that we treat undergo salvage laryngectomy, meaning they've been treated elsewhere at another time period with radiation plus or minus chemotherapy. I think one of the significant findings from this study is the follow-up for our patients. We're the only academic medical center in the state, and we're pretty much in the center of the state. So if you're coming from elsewhere, you might have transportation limitations, and we only had there were 30% of patients who underwent tracheoesophageal puncture who really did not have postoperative follow-up, which is significant because if you're coming from a community without a speech-language pathologist that's adept at tracheoesophageal puncture, speech rehabilitation, you can imagine that there won't be success. So that left us wondering, really, the timing of tracheoesophageal puncture. We found high rates of tracheoesophageal puncture abandonment in our patient population, predominantly socioeconomically depressed population. We found higher tracheoesophageal puncture utilization rates for those patients who underwent secondary puncture rather than primarily. And that might just be patients' ability to gain dexterity in managing their tracheostoma. That might also mean greater time to consider what it means to take care and manage and communicate successfully with the puncture. Secondary tracheoesophageal puncture might also be beneficial in our patient population for older patients, so they can indeed demonstrate manual dexterity and ability to manipulate their stoma. But it also might serve for our patients a means to self-declare their ability to have postoperative follow-up to get the necessary care for rehabilitation. So I think the laryngeal cancer experience that's reported really reflects access to care barriers in terms of when the stage of the patient's presentation and diagnosis, the ability to comply with treatment recommendations, and the ability to comply with recommendations to achieve a relatively improved quality of life, having the ability to communicate. Transitioning to oropharyngeal squamous cell carcinoma, this represents a unique disease process I think that we're all aware of. I think we're aware of the epidemic of human papillomavirus-related oropharyngeal squamous cell carcinoma. With the steady decline of tobacco use throughout the country, except in Mississippi, there's been a steady decline in incidence of oral cavity cancer as well as laryngeal cancer. But you can see from this SEER database graph that over time, there's been a steady rise in the diagnosis of oropharyngeal squamous cell carcinoma. And that's indeed related to reportedly 70% and greater association with the human papillomavirus. I'd like to present or highlight this study where the authors sought to project the associated human papillomavirus vaccination with oropharyngeal cancer incidence in the United States during the years 2020 to 2045. They utilized the SEER database to project the expected cancer incidence for oropharyngeal carcinoma, and they use a teen database to identify those patients undergoing vaccination to derive a rate of diagnosis for that point in time that this study was conducted. What they found was that if people did not change the vaccination rate, the overall oropharyngeal squamous cell carcinoma incidence in the population would increase from 11.9 to 14.3 per 100,000 persons in the United States. With vaccination at the current rate, the overall incidence projection would still increase from 11.9 to 13.8 per 100,000 persons in the United States of America. I mean, you can anticipate that there would be limited effect on the older patient population based on eligibility by age to receive the HPV vaccination. So the majority of incident oropharyngeal cancer in 2045 will be in older populations. You can see in the graphic on the right that based by age cohort, the greatest curve, which is the upper curve in gray, that age group is 70 to 83 years. So you can see that there's a steady rise in the incidence of oropharyngeal squamous cell carcinoma for that cohort. And the decline in the incidence for younger patients is important, is not going to be as dramatic due to the time frame it takes to develop HPV oropharyngeal squamous cell carcinoma. So I think this represents an important epidemiologic change that we should anticipate in the future, because the increased incidence in older patients raises a variety of additional considerations. Older patients tend to have increased concomitant medical comorbidities that require addressing in addition to the treatment of their disease. And that can result in increased associated cost to manage these patients, with an indirect cost to the society as a whole. As you all know, clinical trials are not representative of our patient population, right? They don't include older patients. So it's hard to predict that the treatments that we consider gold standard, how they impact the patients being treated in 2045. Currently, HPV-related oropharyngeal squamous cell carcinoma is truly a disease of young male patients, greater socioeconomic status, who don't typically have a significant smoking history. But over time, older patients with this disease obviously don't have a similar life expectancy, so their goals of care may be different than the current group of patients that we treat with this disease. I'd like to highlight an additional study. I don't know how many of you are aware that there are reports, although few and far between, of a discordance among African American patients diagnosed with this disease with respect to HPV DNA obtained by PCR for diagnosis, in contrast to P16 positivity by immunohistochemistry. So there's been reports of discordance that reflect also in how patients' outcomes are impacted. But this group from the University Hospitals of Cleveland wanted to focus on the difference in outcomes based on P16 status, because they note that in order to determine P16 as an effective surrogate marker for HPV disease, this was done in a predominantly Caucasian group of patients. They included over 400 patients in their study cohort, of which 90%, importantly, were European American. So this graphic depicts the prognostic impact of race based on P16 status for oropharyngeal cancer. The panel on the left demonstrates P16 positive disease in both African Americans and European Americans. The overall survival for European Americans in blue was significantly better than African Americans with a similar P16 disease status. The panel on the right demonstrates similar findings for P16 negative status. European Americans still had better overall 5-year survival in comparison to their African American counterparts. The prognostic impact of P16 was also compared based on Europeans' status versus African American status. So in the panel on the left, for European Americans, P16 positive disease is represented in blue, P16 negative disease in red. There is significant survival advantage for patients with P16 positive disease status. The converse is true for the African American cohort depicted on the right. P16 status at 5 years had no bearing on improving the patient's overall survival, which likely represents some difference in biology. I think the story of oropharyngeal squamous cell carcinoma is a bit unique in comparison to the larynx. These studies presented point to a biologic behavior component for the outcomes of our patients. In fact, the P16 status does not confer survival benefit for African American patients. The University of Hospitals of Cleveland paper, they found that 5-year overall survival with P16 positive status in African American patients, so P16 positive, was comparable to the 5-year overall survival for European Americans with P16 negative disease. So other factors at play, likely contribution from the social determinants of health. But it leads us to question who we provide de-escalation for our patients, or even including them in clinical trials. If the biology is different and we know that patients with P16 positive disease who are African American do worse, is it equitable to have them participate in a de-escalation oropharyngeal cancer trial? The work of Dr. Thomas is worth mentioning because Dr. Thomas was probably one of the first to contribute to the literature on Hispanic Americans with HPV-associated oropharyngeal cancer here at the University of Miami. This was the topic of her Triological Society candidate thesis. She created a database for her patient population here, almost 240 patients, 70% of whom were white, 30% of whom were Hispanic. She was seeking to identify any disparities that could be addressed in the Hispanic population, and she also sought to identify whether there were any unique clinical presentation among the Hispanic population. What she found was that there was a significantly more women representation among the Hispanic group of patients that were diagnosed with disease. She also found that among the Hispanics diagnosed with this disease that the primary site was most often the tonsil in comparison to white Americans, where the primary site most commonly the base of tongue. She also found that in her cohort of patients, the Hispanic patients most frequently had a never use alcohol history. She did not find any significant difference in overall survival outcomes, however. What are the implications of her findings for people that work in areas similar to the University of Miami, where there's a significant Hispanic population? It's important to recognize that Hispanic females who present with odynophagia or sore throat, dysphagia, and difficulty swallowing, particularly if it's unilateral and a neck mass, this should raise the suspicion for oropharyngeal squamous cell carcinoma. And that information should be imparted to primary care providers. Hispanic patients with unknown neck primary should also raise the suspicion for the tonsillar region. We know that PET scans are great in potentially identifying an unknown primary site, but oftentimes they do not, and so it behooves us to examine carefully and biopsy the tonsillar region. It also raises the question regarding Hispanic Americans with this disease. Is there a biological difference here as well, with more being diagnosed in the tonsil as the primary site? Is there an HPV subtype that we don't regularly test for that might be a driving factor for HPV-associated disease in Hispanics? And Dr. Thomas pointed out in her work that the study number might not have been enough or adequate to identify a true difference in overall survival between Hispanics and whites with this disease. As mentioned in the introduction of our fearless colleague, Dr. Thomas was very proud of this work, for which she indeed was honored with the Mosher Award from the Triological Society that reflects clinical excellence in a research project. And she posted this on her social media back in 2016. Dr. Thomas was also lucky enough to have her husband Damon and her 2 sons witness her presentation and received the award, and we were able to celebrate at dinner with one of her Triological Society sponsors, Dr. Jimmy Brown. I think it's also fitting to mention Giovana was a trailblazer and innovator as it pertains to oropharyngeal squamous cell carcinoma. She was one of the lead investigators with the ECOG trial that really established how we address patients with intermediate grade HPV-related squamous cell carcinoma of the oropharynx who are resectable. So she was an innovator with respect to minimally invasive surgery with the robot as well. So I think the presentation of the studies with respect to human papillomavirus associated oropharyngeal cancer highlights disparities with respect to age in the future, biology and race. The difference in survival between blacks and whites is significant and likely pertains to biology. The difference in clinical presentation between Hispanics and whites is a driving factor that should be communicated with the community at large. This is one of the last email communications that I had from Dr. Thomas. At this point, she was already undergoing cancer treatment. Dr. Thomas was still highly engaged with her societies that she loved, the American Head Neck Society and the Triological Society. She was charged with the work of assembling a group of physicians in the American Head Neck Society to develop a consensus statement for managing healthcare disparities. And this is the email communication to that extent. To develop a consensus statement to address disparities in head and neck cancer, I think it's important to consider the social determinants of health, which I've been intermingling in this discussion. The social determinants of health are those factors, non-medical, that impact patient outcomes no matter the disease. They're the factors into which we are born. They're the factors in which we live, the work environment that we are in, age, all of the non-medical factors that impact the external influences on our disease outcomes. You'll often see the social determinants of health categorized in this way: educational access and quality, healthcare access and quality, neighborhood and built environment, social and community context, which this figure that I found does not include biases, and I think it's important that before discrimination, there's implicit and explicit biases at play as well, which should be considered in training our physician workforce. And then, of course, economic stability. So in addressing the social determinants of health and the intersection of the social determinants of health with biology and the medical condition really will enable us to effectively address health disparities toward my personal vision of otolaryngologic health equity. And just 3 best practices that I consider in this presentation anyway are community engagement, the importance of patient navigation models, and bolstering of our underrepresented in medicine pathways towards careers in otolaryngology. As a potential leader of a department, I think that community engagement would be an additional pillar to those of patient care, education, and research. The benefits of community engagement extend far beyond simple physician outreach and meeting and greeting one another. It builds trust with the population that you serve. It builds trust with the referring providers that are caring for mutual patients. It improves communication bidirectionally between the providers at the medical center with the referring providers, with the patients in the community that will potentially become your patient. There's a bidirectional opportunity for education. We can impart to our community the risk factors for disease, the signs and symptoms that they should be alert for to refer for higher level of care. It allows the community leaders to inform us as to potential barriers of a specific population that impacts a patient's ability or desire to seek care at the medical center. It enables us to identify resources and allies in the community to help get those patients in and complete the care that they are recommended to have for their disease, thereby increasing patient access and hopefully all leading to improved health outcomes. Some methods to engage with the community include when you receive a patient that has no primary care provider, it's helpful to identify and refer the patient to a primary care physician in order for the comprehensive medical care of the patient to occur. To establish relationships with community organizations such as churches, community centers. I think one of the most salient relationships the University of Mississippi has is with the federally qualified health centers in our state, such as Jackson Hines Comprehensive Health Center. These community organizations in partnership help us with screening events, educating community leaders, and really building the communication and trust. Establishing connection with community leaders is important, as well as including community leaders on advisory boards and hospital boards. That enables them to influence the policies that we implement in order to treat our patients more effectively. And in a hospital center similar to mine, where a lot of the patients are coming from a rural setting, really leveraging things like telehealth and virtual navigation to help those patients with access to care. This is a quote from Dr. Harry Freeman, a family practitioner in Harlem, New York, who really in the 1990s was the founder and implementer of a successful patient navigation program. And this is a direct quote of his describing patient navigation as a community-based service delivery intervention designed to promote access to timely diagnosis and treatment of cancer by eliminating barriers to care. And in 2012, the American College of Surgeons Commission on Cancer mandated that patient navigation be a standard of care for cancer programs by 2015. I can tell you, as a recent panelist this past spring at COSM on a panel to address how to engage patients with poor patient access, my topic was patient navigation. The other panelists indicated that they don't have patient navigation at their hospital for the head and neck cancer patients at any rate. And this is important. It requires human and financial resources, but really we require stakeholder buy-in to make that happen. I also should highlight that there's no standardization for patient navigation, which really allows for any patient navigation model to be tailored toward the population that is being served. The Oncology Nurse Navigation Society in 2013 actually developed their own framework and care model to addressing cancer patients. Their system is based on how nurses engage with patients of any kind. In the outer circle, this is represented by nursing assessment of a patient, implementation of a nursing plan, and then evaluating the effect of that nursing plan. And this is then utilized in a culturally sensitive manner to, in fact, navigate the patient, advocating for the patients, coordinating the patient's care, educating the patient and their family members, and really just being the communication liaison for all of the patient and family needs that need to be met in their interaction with the hospital organization in which they're receiving care to improve outcomes. As a head and neck cancer surgeon or any oncologist, the nurse navigation care model really devised in these various time points along the cancer care continuum are really just areas of entry for patient navigation to be successful. Every patient is not going to have the same barrier to their care, and so it's important to identify what aspects in the cancer care continuum for the patients that you serve, how you can implement programs to help those patients get the care that they need. This is a wonderful, there's a dearth of information on patient navigation in the literature, I should say. There's really little information as it pertains to head and neck cancer. There was an early paper in the 2015 era out of Tulane where they used a nurse in their head and neck cancer service line to be the navigator to get patients from diagnosis to treatment recommendations. That's it, within 2 weeks. They demonstrated about 50% success with that, and then almost 90% of patients fell within one standard of deviation. So that one early study did demonstrate benefit of navigation. This more recent trial from Evan Grabois and others from an NIH grant called ENDOR was his attempt to demonstrate feasibility and ability to really get a patient from time of surgery to implementation of postoperative radiotherapy within the ascribed 6 weeks that we like. As we know, over 60% of head and neck cancer patients throughout this country are not meeting that time frame. This was a multi-level navigation model that he established, levels being patient issues, team issues, and organizational issues. So for example, with respect to the patient, travel is a problem for many patients, not just in Mississippi. And then organizationally, I think one of the key things is referral tracking and follow-up. In his study, they were able to demonstrate 88% eligible cancer patients were enrolled and retained in their study. 86% of the patients that were enrolled, they were able to achieve that time point of 6 weeks to postoperative radiotherapy. And 86% of the patients surveyed after their participation in the trial were highly recommended the program. It basically consisted of 3 time points where the navigator interacted with the patient to assure that they were meeting the 6-week time frame. I think the effects of oncologic nurse navigation are probably better presented in the literature as it pertains to cancer patients at large. The University of Alabama had an NIH grant where they utilized a lay navigator to demonstrate the return on investment of employing navigation. They were able to demonstrate a reduction of emergency department visits, hospitalizations, and intensive care unit admissions by 6%, 8%, and 11% per quarter over 3 years for over 10,000 patients navigated for all types of cancer. And they also showed a decreased estimate of about $800 per quarter as a result. The Levine Cancer Institute also reporting on all cancer types, but with advanced stage of 3 and 4, approximately 1,000 cases. They demonstrated that for patients who were enrolled in navigation, there was an 18% decrease of care in the acute care setting in comparison to patients that were not part of the navigation model at 30%, and that was statistically significant. I think that we've been talking a lot about lay navigator, nurse navigator. The Wake Forest Baptist Comprehensive Cancer Center came up with a novel type of navigator called a population health navigator. This was fascinating to me because instead of directing their navigation efforts to a specific disease type, they directed their navigation efforts to specific population types of the patients that they served. Their catchment area included a lot of rural patients, Black patients, and Hispanic patients. So that's how the navigators were deployed to assist in managing the healthcare system, to facilitate access to the quality care needed. But one of the most important things that these navigators did, because it wasn't based on disease site, it was an opportunity to educate patients and their families on the importance of clinical trials, why you should participate if approached by your ultimate oncologist. So they were able to demonstrate that pre-navigation inclusion in clinical trials is the middle bar graph of the catchment area, which is the left bar graph. So you can see a considerable increase in the number of patients recruited, both rural, Black, and Hispanic, after the implementation of a population health navigator that helps the patients understand why clinical trials are important. So I'd like to share a little of the University of Mississippi experience. I think people like me who are not from Mississippi, for no matter what medical specialty we practice, the attraction of going to the University of Mississippi is really to make an impact on patients' lives. And that's because Mississippi ranks last in virtually every leading health outcome. Our state is unique. There are 82 counties, of which 80% are considered federally rural. In many of them, there's no physician access. Some have nurse practitioners, but many don't have that either. There's about 3 million people in our state. Unlike the US Census, there are 60% white people in our state, 40% Black, which is significantly more than the 13% nationwide. The median state income is $45,000 per household. 18.7% of people in Mississippi live in poverty, in contrast to 11.5% nationwide. Just 22% of people in Mississippi earn a college degree, in contrast to almost 40% nationwide. So these things all impact health literacy, access to care, finances to achieve the care. I hope that I'm pointing out that navigation is essential. It's also multifaceted, as Dr. Graboy's study pointed out in his graph. So in 2017, I left the University of Illinois, went back to the University of Mississippi, asked for a nurse navigator. Our hospital has always had a breast navigator, and that came about from an NIH grant, really demonstrating the model of effective patient navigation. 2018, we had a new cancer director, and he was a lung oncologist, and he came with a lung navigator, 2 navigators. So I finally got a nurse navigator for head and neck cancer that began work in August of 2023. And so this model is from the bottom up. I think one of the main things that we encountered with our patients is what we wanted to try and address by implementing the navigation model. There are so many more things that we want to address. But to begin, initial telephone contact is crucial. Patients were coming from all over the state, often 4 hours away. They would have a ride that would think they were going to get back home in the afternoon to go to work. This was not possible because our idea for the patient was to not only see us, but to see the medical oncologist, the dentist, get some blood work done so that we could assess their nutritional status and have the oncologic dietitian work with them, see the speech language pathologist, and the radiation, both oncology teams. So really their day was so long, there was no way a ride would get home to work the same day. Oftentimes patients were referred and would arrive at this building that says Cancer Institute and not actually know that they have a diagnosis or a suspicion for cancer. And so if patients are coming in and not anticipating a discussion about cancer, this creates a problem in them actually hearing and listening to what the plan of care is, which is, as you know, quite complex. And it allows, in that initial telephone contact, an ability to identify specific social determinants of health that we can potentially manage or start managing before a patient even appears by making the palliative referrals necessary to get through treatment. We have a group called the Evers Care that they provide things such as food pantry, transportation. There's Uber share for patients. They have several resources available to our patients. The Center of Integrative Health is another center that we also refer our patients to. They employ significant mental health education as well as apparatus to address mental health issues such as exercise programs. It's not as simple as exercise, but it's integrated into their cancer care continuum. And again, the nutritional status is evaluated. And I think with respect to the treatment piece, the radiation oncology strategy required significant addressing, and I'm going to show that in a second. This is just from EPIC. Our nurse navigator with that initial patient contact by telephone creates an encounter, and she's able to click on the specific social determinants of health that she identifies. When you click on that, it allows you to enter commentary to describe the specifics of what that may be. For example, we commonly had patients that actually had a home, but when you discharged them after surgery, there was no electricity and no running water to effectively manage their postoperative care and in a safe environment. So these are things that these four are the ones that she tries to focus on: financial resources, so that at the initial visit, the patient can see the financial navigator, transportation needs, food insecurity, and housing. The radiation oncology team, this is not intended for you to be able to read. They implemented something to help manage patients along the continuum from initial consultation to initial start of radiation as well as completion of radiation. This is called the Smart Clinic Smart Board. It integrates with EPIC. The one thing it does not integrate is the time from physician placing the referral in EPIC to the initial actual visit. Something that we're working on. But the green highlights specific time points from referral to initiation of radiation, including simulation, including dental assessment, to green demonstrating that they have met the specific time frame, yellow indicating that there's a impending time frame task that needs to be addressed, and red indicating that the time frame has been missed. But this Smart Clinic Smart Board is throughout all rooms in the radiation oncology suite to really keep everyone on track and getting a patient to timely radiation therapy and through completion. This was published, early work demonstrating that time from consult to first treatment, the number of days was significantly decreased by 8.5, and the total radiation therapy package time was also significantly decreased by 14 days. Again, we're trying to establish means to assess the time from initial patient referral to radiation and the first visit, which impacts these numbers as well. This is our fearless patient navigator. She is currently working on the ACS Lions training to identify additional support mechanisms for our patients. Our current areas of focus are pretty much what I've discussed, addressing transportation, both pre-treatment to get to all of the appointments necessary to begin treatment, throughout treatment, and then, of course, onto survivorship. The coordination piece is extreme for us. 30% of our patients get all of their care with us, but as you can imagine, as the only academic medical center in the state, people are coming from so far, it's not feasible to have radiation daily in Jackson. So coordinating that care externally will be the next phase of our navigation program. And she's really working on means to address food insecurity and health literacy. Thank you, Tisha. I think oncologic nurse navigation is necessary for the delivery of quality, complex healthcare. Obviously, in identification and managing social determinants of health, it not only helps patients become diagnosed and complete their treatment, it also helps patients get enrolled successfully in clinical trial and follow through with the clinical trial, and hopefully, in the long run, improve patient outcomes, as demonstrated by other studies outside of head and neck. Again, I think the oncologic nurse navigation is amenable to tailoring to specific populations served. I think in experience that one navigator, more than one navigator, is quite beneficial. When Tisha was initially hired, we had just lost our head and neck clinical nurse. So it's impossible for a clinical nurse to really do an effective navigation. So you really need more than one nurse. And lay navigators have a potential for significant impact clinically, bridging the gap from physicians to the patients and their families. I think that most of us are familiar with the leaky pathway of underrepresented in medicine to otolaryngology. Dr. Thomas was, as mentioned earlier in her introduction, a real advocate for advancing underrepresented, high-quality individuals in our specialty. This leaky pathway diagram demonstrates that the U.S. Census includes 13% Black and 18% Latinx, but we're already behind when we get to medical school with 7% Black and 6.4% Latinx. And that continuum is across the entirety from residency through becoming full professors, with less and less along each stage of that pathway. I think there is merit in the statement that you do not become what you do not see. As a person that is a first-generation college graduate, I never had exposure to medicine or had any contemplation of a medical career. Yes, I was good in math and science, pursued engineering. It wasn't until later that I had the fortune to discover otolaryngology and great mentors like Dr. Thomas to fulfill my career dreams. Ways to address this pathway, the leaky pathway, are broad. I think the work by Nth Dimensions in the orthopedic space is of note. They have a program that begins with early exposure to high school and undergraduate students to expose them to not only medicine, but their specialty. We have similar program for this at the University of Mississippi for all surgical specialties together. But this is key to introducing people that aren't exposed to medicine early, that indeed there are these other things within medicine besides your pediatrician. The really key point of the Nth Dimensions model is this immersive experiential event that occurs between the first and second year of medical school. Students are required to apply, and there are sponsors all throughout the country that sponsor a student to do a 6 to 8 week clinical exposure and research experience. They gain valuable skills in formulating a clinical research question, bringing it to fruition with the anticipation of presenting at the National Medical Association meeting in that summer. They're also expected to have a publication prepared that might obviously require revision, but they're gaining critical skills early on. And they're also establishing mentorship relationships that can become lifelong. I think as it pertains to faculty, again, you don't become what you don't see. It's important for institutions and departments of otolaryngology to continue professional development for people that look like me, to retain people that look like me so that we are available and seen, and give back in mentoring others in the field. And why is this important? I think there are many studies that show the concordance between patient and physician help improve communication, which builds trust, which leads to a patient's greater likelihood of adhering to the treatment recommendations made. And it also improves patient understanding. They're more comfortable to ask questions for clarification. And it leads, obviously, to patient satisfaction, even in the event where they don't necessarily do well from their disease process. I'm going to share a story because I am frequently told by patients who are African American that they're proud to have an African American female as their doctor. This one gentleman in particular needed a free flap, so he needed 2 surgeons. All of my partners are female. So the day of surgery, after being excited to have me as his doctor, I check him in. I'm the first doctor to see him that day. everything's fine. He doesn't have any additional questions. I get up to my office, and about 20 minutes later, I receive a page saying this patient is about to leave. He doesn't want to have surgery. So in the interim between me seeing him, he's encountered the anesthesiologist, who was female. He encountered my partner, again, who he had already met, also female. And then he said that he just doesn't trust women. So I say this, I'm telling this story to say that this is a representation of implicit bias. This patient was clearly afraid to proceed with surgery, but the implicit bias comes out. I'm not presenting information about patient concordance with patients to say that Black patients should only see Black doctors. The onus is on us to be culturally sensitive in how we communicate with patients, recognizing their barriers that may be not verbally said, but may be said with respect to how they interact with their body language. These things are important in best serving our patients and mitigating disparities. To highlight biology and the medical condition, again, MD, PhDs, and clinician scientists, we all know are a rare breed. The data from the AAMC from 2018 through 2022 really demonstrates a disparity in the number of underrepresented persons pursuing surgeon scientist or clinician scientist careers. Most people are white, almost 60%, followed by Asians, almost 30%. Blacks and Hispanics represent about 10% applying for MD, PhD programs. Surgeon scientist careers, again, rare breed, but it requires surgeon scientists for us to advance the care that we deliver to our patients. Dr. Thomas, as I alluded to earlier in a fun fact, she was exposed to research, had a love for it, did an NIH research fellowship, and really started her career as a surgeon scientist. But in order to continue the support of surgeon scientists in this era where clinical productivity is the main focus, it requires creative and innovative solutions to maintain the surgeon scientist, including startup packages, consideration of how chair endowment funds are employed, incentivization, not just for the surgeons, but also for a surgeon scientist are important. Maintaining protected time is critical. Oftentimes, we as surgeons will operate in our academic time, but for a researcher to be truly productive, they really need to have that time protected. And I think it's also important to note that there needs to be a mutual and realistic compensation plan for a surgeon scientist who is not going to have as much clinical productivity as regular surgeons. Underrepresented surgeon scientists are important for generating those inclusive and innovative research questions that aren't necessarily at the forefront of the mind of majority researchers, to develop potential specific biologic targeted therapies, which is a great focus right now with respect to cancer throughout the continuum and disease sites. And also to help consider and develop alternative treatment regimens. I think other considerations that underrepresented surgeon scientists bring are clinical trial design, accounting for social determinants of health to get them included. So my call to action is this. Patient navigation. I hope I have imparted the importance of really improving patient access includes patient navigation to build trust, education, and ensure that every step along the way of the cancer care can be met. Community engagement is critical. It might just turn up the next generation of otolaryngologists. It helps with patient and healthcare providers in their education and the population at large. And the importance of developing pathways for women and underrepresented individuals to increase educators, to increase the leaders in our society, surgeon scientists, and culturally appropriate surgeons. This is from the International Head Neck Society meeting in 2016 in Seattle. The panel on the top right with three of us shows Dr. Tamara Watts in the middle, one of Giovana's mentees. Giovana took so much time at this meeting in particular to really rein in Tamara and I, who wanted to attend the meeting because that's what you do when you go to meetings. But she was like, no, I need to talk to you. I need to get an update on what's happening. So she took us to the Space Needle, and just all day we had opportunity to not only have fun, but to get advice and for her to listen to what was going on with our practices. She would be proud to know that Dr. Watts just earned her first R01 NIH grant this year. I think Dr. Thomas would be proud of not only me and Tamara, but all of the mentees that she has had the fortune to impact with her generosity, advice, all of her time, and really just a commitment to help us be the best surgeons that we can be. I'd like to conclude with the fact that Giovana was a woman of faith. This verse from 1 Corinthians, no one should seek their own good, but the good of others. This was truly embodied by Giovana, who was not only generous with all of us, but obviously with her patients, caring for them through her illness to the end. And that's all I wanted to say. To get your credit.
Gina, thank you so much. Giovana taught you very well. That was a very impressive talk, and you already answered a lot of my questions that I had. So I wanted to open up to the audience for any questions that you might have for Gina. Frank.
Because it tends to be only at the front end, and I think having them follow the patient longer, maybe giving the front end more careless factor to improve. So I'm super interested in how you do it, and how they help patients get to the next steps after the initial treatment. I'm super interested in the finding of the Cleveland study that there's no difference between HPV negative and HPV positive. I'm sorry. I was very interested in the study that showed no difference in HPV negative or HPV positive, P16 negative, P16 positive oropharyngeal cancer in the African American community. Do you think it's a biologic difference because they're African American, or could it be a stage difference? Did they break it down? Could it be that when you present at an advanced stage, you don't pick up the differences, or that was controlled?
There are other studies, as I mentioned, I didn't present the data, but there are other studies that actually test both HPV PCR as well as the P16 status. There's probably something biologic where either there's a different HPV subtype that we're not testing for, or there's actual difference in the mechanism of the P16 INC pathway, whether it's downregulated or upregulated, because there's more than one study besides that study out of Cleveland. They just had less numbers of patients. That's why I included that one. There's a study out of Fox Chase, Jeff Liu, who presented the discordant data, HPV with P16, and there's a couple other studies that also present that data.
Dr. Shragi has a question.
Thank you very much for this presentation and really inspiring us with Giovana's mentorship and really kind approach to show us how we can be the best possible physicians. You mentioned about early exposure to help inspire diversity of workforce in otolaryngology. One of the challenges that you actually we encounter is to expose high school students to medicine. Because you mentioned that the first step is to expose underrepresented population to our field, medicine or otolaryngology, anything else. So one of the big challenges that we have is that the structure that we have now, even in University of Miami, is not appropriate to this exposure to high school students. they are minor, we cannot get them to our lab, to our places, because the rule are very strict about those things. So what do you recommend to overcome those challenges?
So I didn't expound upon the model, but really it involves a lot of utilization of the reps from various medical companies that we use to have kind of labs outside of the setting of the medical institution facility so that you can facilitate these. We've gone to high school auditoriums to have clinical simulation with plating, for example. So they get their hands-on experience with plastic skeletons and plating as sponsored by Stryker, for example. And you have the opportunity as well to present a quick PowerPoint on what it is to be an otolaryngologist. I usually give a presentation on the various subspecialties with not gross gory pictures, but to give an idea of what it is an otolaryngologist does. And I usually say something about how to get into medical school, resources. I provide resources for that. But I think there's many who do this already throughout the country. It's not a concerted effort, which is part of the problem. I think the work from Dr. Bonnie Mason, the founder and former CEO of Nth Dimensions, and they published work where it took 15 years to see a noticeable difference. But at 15 years, Dr. Mason was able to demonstrate that of the 400 underrepresented persons practicing orthopedic surgery, 80 of them had gone through the Nth Dimensions model. So the work is feasible, the work is productive, and can result in true change. It just doesn't happen overnight. And we're surgeons. We like things to happen overnight.
Thank you so much for that talk. I think it was wonderful. I think so many of us deal with different diseases where we see the impact of care delays and how that affects things, whether it's cancer or other types of diseases. I think specifically about some of my CSF leak patients, intracranial hypertension, and trying to figure out how we can really engage our physicians in the community so that they know more about that disease or some of our other diseases. I'd love to hear maybe some of your advice on how to engage some of the physicians in the community, your experience with that, so that we can all learn from that and maybe implement it here.
That's a great question. I think some of my examples, obviously I'm in a small state where we can easily drive to all locations of patient catchment area. One of the things that we do as service line groups, the pediatric groups, for example, of pediatric otolaryngology, pediatric neurosurgery, pediatric plastic surgery, and pediatric neurology, they all travel to 2 hours away to Hattiesburg to have a CME session where they were able to have direct interaction with referring providers and educate them on what signs and symptoms of specific diseases they should consider higher level of care for. So it's those kind of events that we hold a lot in our state from all, not just otolaryngology, but all of the specialties because of the health disparities that our state experiences. Does that help?
Don, do we have any questions from the online people? No? Okay. Fred?
Gina, really enjoyed your presentation. To follow up Adrian Ashragi's comments, the American Neurotology Society sponsors at every academy at a local low socioeconomic high school a program to sort of introduce them to the ear and hearing and that sort of thing. And it's always well attended and there's a lot of excitement around it. I think the issue, as Adrian brought up, is follow-up afterwards. You get the kids excited and the teachers excited, and maybe there needs to be some, a larger umbrella. Maybe the whole academy needs to get behind things like this rather than just individual smaller subspecialty societies.
No, complete agreement. I'm sorry I didn't catch that aspect of your question. I think it would be important to establish a database after all of these events are held, because obviously if we're addressing and having these events for high school and undergraduate students, we're going to continue to have events that are targeted towards entering medical school, having events that are targeting the younger medical students so that they become interested in otolaryngology and do the things necessary to be a successful applicant. So establishing a database for all of the events that we hold with high school and undergraduate students allows us to contact electronically to alert them to an event that might be upcoming in the area in which they live and are studying. So I think you're right. There's fragments of people doing this work, but it needs to be more unified to achieve a lasting result.
Just a question. You really outlined very well some important ways that we can help with this challenge, with navigation, with encouraging training of underrepresented minorities and community engagement. The question I have is about navigation, because I think that, getting into the weeds is really important. My concern is about, it seems like from a government standpoint, maybe we're getting away from a real focus on these issues is the concern. And how is your institution funding the navigation? And just for budgetary planning, how many navigators do you need per what number of patients generally to achieve what you've been able to achieve?
I think with respect to funding, you heard that it took 5 years for me to get the position approved and then another year to actually find a qualified person. The funding is different for all three patient navigators. The breast navigator still is under funding from a grant, and that's because the disparities with respect to women with breast cancer in the state of Mississippi is so extensive that grant keeps getting renewed. So that's how that one's funded. The lung cancer, the lung oncologist patient navigator was funded through an endowment because he was the chair and the director also of the Cancer Institute. Mine is funded in part by the Department of Otolaryngology and in part by the Cancer Institute. And that took some time. During COVID, the lung oncologist left due to increased age, but the interim director, I kept in his ear about the importance of navigation, and he eventually approved the position with the allocation of funds that were matched by my department chair. So I think it requires creativity. I can't answer how you can achieve that within your specific institution, but creative thinking to make it happen. Dr. Gravoy's study was from an NIH grant. I think focusing on the specific issue for the patients that you serve might result in funds, although with the results of the new election, that might not be the case. But it's worth trying the grant route as well.
All right, bring up Don.
So thank you so much, Gina. That was just a fantastic presentation. I would add that here at we have a robust nurse navigation program, but we've seen it undergo evolution over the years. And ironically, when it started, it was very patient focused. And as the program has grown and as the cancer programs have gotten busier, it's just an incredible challenge to keep it at the navigator to patient interface in a very personal way. There's so much data to acquire, so many things that have to be coordinated, that one-on-one interaction has gotten more distant. So having a program is essential. Making sure it continues to flourish is the next challenge once you've achieved that first obstacle. With that, I just want to thank first, before I award Dr. Jefferson her plaque, the support of the American Head Neck Society and the Triological Society in publicizing this talk. We had a number of participants on Zoom, have a number of participants on Zoom who are listening nationwide. And without the support of those two societies, that would not have happened. So we are deeply grateful for that support. But now I would like to award Gina her plaque, and I would like to read it. This is to Gina D. Jefferson, inaugural speaker of the Dr. Giovana R. Thomas Memorial Endowed Speaker Series, honoring the legacy of Giovana Thomas and her unwavering focus on head and neck cancer care, clinical and translational research, her special interest in disparities in head and neck cancer and otolaryngologic disease care delivery and outcomes. The Thomas Lectureship is an enduring testament to her love of education and her mentoring efforts on behalf of future generations of head and neck surgeons. And Gina is a terrific embodiment of that, a tremendous legacy of Dr. Thomas's mentorship, and we are so honored to have you give this first lecture in the series. And with that, we invite everybody to the reception outside. And thanks for everyone for attending on Zoom.